Okay, I'll go ahead and get started here. Welcome everyone to our second annual Interdisciplinary Health Data Competition at the University of Minnesota. This is a truly collaborative competition led by Millie with strong collaboration from School of Public Health, the Medical School, College of Pharmacy, Institute for Health Informatics, and many other colleges, and the Nursing School, and many other colleges and departments as well. Very, very strong competition this year. We had 94 students competed in 24 interdisciplinary teams representing 12 schools at the university. The challenge that we assigned this year was an exploratory analysis of the public use COVID-19 hospitalization datasets released from the US Department of Health and Human Services, together with any other publicly available data that the competing teams could get their hands on to assess the health disparities and community impact of COVID-19. We want to thank all our competitors for this competition. And now in this event, we have 5 finalist teams that will present you their work. I would like to also send a warm thank you to our judges. We had an incredible number of 18 judges in our first round, and we have 7 other judges whom you will meet briefly right now in the second round. And I would like to also thank our sponsors, United Health Foundation, Bind, Accenture, Medtronic, Office of Academic and Clinical Affairs at the University of Minnesota, and Frederickson and Byron. We have awards for the winning teams today, with the first place team being awarded $4,000, second place team $2,000, and third place team $1,000. With that, I will introduce you to our first teams. And our first team is going to talk about how is Minnesota vaccinating its counties against COVID-19. But before our first team maybe takes on stage, may I please have our second round judges just briefly introduce themselves. We could start with Protima.
Sure. Can you hear me?
Yes.
Hi, everyone. I'm Pratima Advani. I'm one of the lead researchers at UHG Center for Healthcare Research, leading a lot of our research, both with academic institutions as well as leveraging our own data asset to find ways in which we can improve the healthcare system. So really interested in hearing what ideas everybody has today on leveraging data in the COVID space. Thanks for having me.
Darren?
I'm Darren Dickerson. I'm a Senior Director of Global Portfolio Strategy and Business Model Innovation for our Defibrillation Solutions business. It's part of our cardiac rhythm business, where we focus on CRT-D and ICD families of products, and excited to be a judge today.
Thank you, Darren. Michael?
Hey, good afternoon, everyone. Michael Jones. I'm a Managing Director with Accenture here in our Minneapolis office. I'm responsible for our healthcare provider Midwest business, so dealing with hospitals and clinics all throughout the Midwest. And so these are very timely topics that I'm certainly anxious and excited to hear about. Thank you.
Thank you so much, Michael. Tamara?
Thank you, and good afternoon, everybody. Tamara Lair. I am the Chief Analytics Officer at Bind, and you saw that Bind is a sponsor, and everybody's saying, "What's Bind?" Bind is is the first personalized health plan startup health insurance company, doing lots of interesting and disruptive things. My team is responsible for evaluating how Bind is working, how could it work in the future, and I'm one of the people that's also involved in a very large effort, because Bind fits perfectly into a model that really accelerates equity and narrows disparities in healthcare. So we're particularly leaning into part of the topic that's focused today. I'm a health services researcher by training, worked for the federal government for a long time, for organizations with lots of letters, and I'm happy to be here today.
Thank you so much, Tamara. Nick?
Hi, my name is Nick Madison. I'm the System Director for Clinical and Quality Analytics for mHealth Fairview. So I am responsible for this data. The data pretty much used in this and the data you see in the news, my team extracts, transforms, and sends this data to the federal government among one of the entities. I'm a proud U of M MHI graduate, and I'm a Mspe mentor as well. So I'm really excited to see some of this cool use of the data that I'm personally pretty tied to. So,
thank you so much, Nick. Pam?
Hello, I'm Pam Mink, and I'm an epidemiologist and Director of Health Services Research at the Minnesota Department of Health. In my job, I lead the research team that works with the Minnesota All-Payer Claims Database, and those were the data that were used in last year's competition. So happy to be here as a judge this year.
Great, thank you. And Mark?
Hi, everybody. Mark Weed, I'm chair of the Mayo Clinic Division of Engineering. The pandemic has really consumed most of my professional and personal life over the last year. And so I was really excited to have this opportunity to see how the teams are going to make use of data to address some of these health disparities. So really looking forward to seeing what the teams have to present.
Thank you to all our judges. And I guess I forgot to introduce myself. I'm Pınar Karacamandic, and I'm the academic director of Mspe. Before I hand it off to Team One, I also want to thank Kim Choi, Mspe's program administrator, because she's the person who made everything happen. Thank you, Kim. All right, Team One, please share your slide, and we're looking forward to hearing from you. Good to go. Thank you.
All right, hello everyone. Thank you all for joining us on our presentation on how is Minnesota vaccinating its counties against COVID-19. My name is Serena Zhang, and I am a PhD candidate in the Social and Behavioral Epidemiology program at the Division of Community Health and Epidemiology at the School of Public Health. I'm one of 3 students that comprises Team One. My colleagues Emily and Kellen will also be co-presenting with me today, and I'll allow them to introduce themselves as well.
Hi, I'm Kellen. I'm a PhD candidate in the medical physics program in the School of Medicine.
Hi, I'm Emily Verity. I'm a PhD candidate in epidemiology at the School of Public Health as well.
Great. So our team is actually a combination of translational research and career training pre-doctoral fellows within the CTSI at the University of Minnesota. And so we're really excited to share with you all our approach to the 2021 Interdisciplinary Health Data Competition. So since the COVID-19 pandemic began a little over a year ago, more than 500,000 cases and almost 7,000 deaths have occurred in Minnesota. The burden of this disease, however, is not equally shared. Furthermore, COVID-19 has exacerbated existing health disparities between racial, ethnic, and socioeconomic groups, as well as urban and rural communities. Equitable rollout of medical countermeasures, like the 3 currently approved COVID-19 vaccines here in the US, can help to curb these growing disparities. While our team had the opportunity to scale out our approach and analysis to any geographic means and outcomes, our team is purely motivated to understand and contextualize what is happening on the vaccine front regionally here in Minnesota in order to provide timely and feasible assessments of current rollout efforts and to offer up solutions and strategies to improve COVID-19 vaccine coverage within our state. Our overall aim, therefore, is to examine the relationship between vaccination rates and county-level characteristics to develop a predictive model of vaccination rates in the state of Minnesota by county.
Our approach innovatively applies machine learning techniques, specifically gradient boosting modeling, to a wide variety of publicly available data to inform our predictive model. First, we model the vaccination rate over time using weekly vaccinations by county from December 14th to March 5th. Then we examine the correlation between county-level characteristics and vaccination rates to select important variables to include in the predictive model. Finally, we use gradient boosting regressors to identify strong correlates of that rate based on the variables selected. This method is well adapted to sort out the strongest predictors, even when county level characteristics are related to one another. Our overall outcome is county level characteristics that are most predictive of vaccination rates in Minnesota. Our unique data set is combined of 7 different sources representing a combination of sectors, from finance and employment to transportation to health and human services. The shaded variable and data sources that you see on the screen represent both data sets that were provided by the competition. Weekly vaccination counts were provided by the Minnesota Department of Health, and adult population statistics were taken from the 2019 US Census. The community profile report provided data on the impact of COVID-19 as far as the number of cases and deaths per county, as well as several indices that demonstrate vulnerability to COVID-19 and socioeconomic vulnerability. We also looked at county demographic data, including race and ethnicity, age, poverty, and average household size. We also used the COVID-19 reported patient impact and hospital capacity by facility data in order to capture the weekly burden of COVID-19 on hospital utilization. This includes the hospital facilities per county, as well as peak utilization rates over 2020 and 2021 for the dates that data was available. Please note, we aggregated the facility level variables at the county level, and then we took the maximum values for a given period in order to demonstrate the peak burden for COVID impact over that time. The Minnesota Healthcare Directory database provided the number of nursing home facilities and nursing home beds by county. And the Minnesota Department of Employment and Economic Development provided the data on peak unemployment rate per county, as well as broadband internet coverage by county. Finally, we also referred to the CDC's Data Tracker's COVID-19 Pandemic Vulnerability Index, the PVI, and looked at not only the overall index, but some of the categories that make up the index, including county level measures of social distancing, population mobility, and the prevalence of comorbidities.
We use simple linear regression to model the vaccination rate in each county. The time since the first vaccine doses were administered on December 13, 2020 is our covariate, and the cumulative first doses administered to the adult population in a county is our outcome. In this scheme, the slope coefficient of the line fitted is the percentage of the adult population administered a dose each day. Next, we used our socioeconomic and COVID-19 covariates to predict the estimated vaccination rate using a gradient boosting regressor. We chose gradient boosted models because they frequently have the highest predictive accuracy among model types. They work well with small sample sizes, and because GBMs are based on simple decision trees, we can analyze the variable importance and the partial dependence of individual covariates. The chart you see depicts our model training process. Because our dataset is small, we use cross-validation to estimate the model error rate. Briefly, the data is split into training and validation sets. Variables are selected and the model is trained using the training data, and then that model is tested using the validation split. This process is repeated several times, and the root mean squared error is averaged to give our model's estimated error rate. Now we can take a look at some of the results. First, I'll talk about the estimated vaccination rate. The rate ranged from 0.21% of the adult population vaccinated per day in Sherburne County to 0.76% in Cook County. The map reveals trends in the vaccination rate. The lowest rates are observed in the counties neighboring Hennepin and Ramsey County, while the highest rates tend to be in some of the rural areas in northern Minnesota and along the Minnesota River Valley. Cook and Monoman County are the exemplary outliers here. You see them on the map in yellow, and we'll have more to say on them later. Now we'll look at the results of our vaccination rate predictor before talking about our covariates. To gauge our model's performance, we ran a quick baseline predictor, which predicts the vaccination rate as the mean vaccination rate across all the counties. This model performs with a root mean squared of 0.094. Our gradient boosted regressor performs with a root mean squared error of 0.073, roughly 25% improvement over the baseline. This suggests to us that some of the county level covariates yield predictive information about the vaccination rate in the county. We'll take a look at some of those covariates now.
Here we present the correlations between all variables and the county vaccination rate. And for you, we've given the top 10 most correlated variables. Positively correlated variables are in blue, and negatively correlated variables are in red. We took the inverse of the social distancing index that is included in the pandemic vulnerability index in order to make it more intuitive. So in our case, positive values of social distancing indicate more adoption of social distancing behavior. And as we see here, social distancing is correlated positively with higher vaccination rates. Conversely, population mobility, or the proportion of the population that are in an area during daytime, was negatively correlated with the county vaccination rate. We can examine the distribution of these variables by county using the administrative area map of Minnesota. So you can see here that increased social distancing, or the inverse of the social distancing score, was pretty widespread around the state, with the exception of those counties surrounding the Twin Cities metro, where there were lower levels of social distancing. As this was negatively correlated with vaccination rates, improving vaccination in these areas would be really critical for controlling disease transmission. Registered vaccine providers, or the number of the total vaccination sites per adult, were found to be more concentrated on the western side of the state. So we see higher numbers of vaccination sites per person along the border with the Dakotas. Also, we see that as predicted, the percent of the county population over the age of 65 was more concentrated in rural areas, especially in Aitkin County in east central Minnesota in yellow. Looking at more of the variables, we can see that the highest population mobility, or population size during the day in the Twin Cities metro, is concentrated in Ramsey and Hennepin County. The largest household size on average corresponds to the counties surrounding the Twin Cities metro area and other counties scattered throughout the state. Finally, peak hospital utilization in terms of the percent of beds occupied by COVID patients were greatest in the Pine and Kennebec counties along the border with Wisconsin, as well as Redwood County in the Southwest. These counties were experiencing a greater COVID burden relative to their hospital capacity at some point during the pandemic. We see the high vaccination rates in Monoman and Beltrami counties, where a large proportion of the population is Native American. Monoman County is the only county located entirely within a Native American reservation. The White Earth is a sovereign nation, and White Earth leaders extended vaccine eligibility to anyone over the age of 18 living within the White Earth reservation boundaries, whether they belong to the White Earth Nation or not. As of February 19th, Monoman County had vaccinated over 85% of people aged 65 and over. Monoman County receives vaccine allocations from the state of Minnesota, from Sanford and Essential Health Systems, and from the federal government as part of the Indian Health Service. So Monoman County is a bit of an outlier compared to the rest of the state in terms of the eligibility requirements and vaccine allocation.
Partial dependence plots can be used in conjunction with tree-based ensemble methods to visualize how covariate affects the predicted vaccination rate across its range. The assumption of these plots is that the rest of the covariates are already included in the predicted rate. So these plots alone do not constitute a correlation between the covariate and the vaccination rate, but instead represent how the model uses the data to influence its marginal prediction. We see that higher values of social distancing, registered vaccination providers, and an overall older county population results in higher vaccination rates, but also that lower population mobility, household size, and the number of hospital beds occupied by COVID-19 patients results in higher vaccination rates. Our models come with a few limitations. The first is that we assume that the vaccination rate in each county was linear. In a few months, I fully expect that the vaccination curves will look logistic. And indeed, for Cook and Monoman counties, a smooth plot of the cumulative vaccinations already exhibits the tapering you'd expect from a logistic curve. However, as evidenced by high R-squared values and random appearing residuals from our linear fits, most counties are in the steep linear regime of the cumulative vaccination curve. So we think our assumption holds for the time span examined. It also makes it easier to interpret. Second is that when we scope to county level data for Minnesota, we limit our sample size to 87, which is small for predictive modeling. Scoping the county level data also aggregates much of the racial and ethnic differences that exist on a zip code or neighborhood level. Had zip code level data existed, we would have been able to elucidate more about the inter-county disparities in vaccination rates. Finally, there's a bewildering number of possible covariates and factors that can influence the vaccination rate, and we've only included a sample of these. In particular, we didn't try to estimate vaccine hesitancy. But now we can discuss some of the implications of this work and how this data can help shape policy choices.
So how has vaccine rollout been working in Minnesota? We've seen a linear increase in vaccination by county in the state, indicating that our vaccination rates keep increasing from week to week. In addition, those counties with more vaccination providers per capita had greater vaccination rates, which may reflect the prioritization of health workers in early stages of vaccination rollout, as well as the ease of access to vaccine providers for the general public in those areas with more of them. We also see counties with a greater population over the age of 65 having greater vaccination rates, which is in line with age-based guidance for vaccination. Finally, higher proportions of Native American population were associated with higher vaccination rates. But a word of warning, the county level inferences do not necessarily apply to within county distribution of vaccines. On the graph on the right, we see the proportion of each racial and ethnic minority group in Minnesota represented in blue, and the proportion vaccinated in gray. Despite the success of vaccinations in places like Monument County, we still see overall low vaccination rates among Native American populations in Minnesota compared to their white, non-Hispanic Minnesotan counterparts.
While the COVID-19 vaccine rollout here in Minnesota has been robust, there are opportunities to increase efficiencies and improve greater coverage. We propose 3 solutions that may help to facilitate these improvements. First, increase statewide opportunities to train and register COVID-19 providers. Currently, the process is quite fragmented and decentralized. Providers must go through the Minnesota Department of Health to register, but complete training through the Centers for Disease Control. So streamlining this process may make it easier for providers to train and become COVID-19 vaccine providers. An increased healthcare workforce of registered vaccine providers in turn then enables more opportunities for vaccine administration. Secondly, several Minnesota counties, as referenced earlier, are doing an optimal job at vaccinating their municipal populations. The MDH, or the Minnesota Department of Health, or the Region 5 Public Health Training Center can establish communities of praxis or learning cohorts to disseminate vaccine rollout best practices and processes. This cross-sectoral approach between various public health personnel and entities encourages collaboration and sharing of ideas and strategies that already work well in the field. Finally, the Minnesota Department of Health can continue to expand their community-based vaccination programs by providing more pop-up events in counties with low vaccination rates. Implementation of these strategies are highly practical because they utilize existing infrastructures. The evaluation of these cross-sectoral approaches also will require a diverse set of data, including the continued surveillance of COVID-19 vaccine data provided by the Minnesota Department of Health, as well as increased data sharing from various sectors, from healthcare to finance to transportation and so forth, and also robust engagement with key stakeholders like providers, county public health personnel, residents to evaluate key processes. In summary, Minnesota is doing optimally well for its current vaccine rollout strategies, aligning its priorities with CDC recommendations to target high-risk populations. However, there are opportunities to improve and maximize current strategies, and these should be utilized to increase vaccine rollout and reduce the spread of new variants. Thank you all for attending our presentation, and we will now take questions.
Thank you, Team One. We can have judges just unmute themselves and go ahead with questions, please. We have 5 minutes.
I had a question, this is Tamara Lair, about, and it may be about the data, but I was interested in the social distancing findings in particular. to what extent do you feel that like those are really reflective of population density versus reflective of actual sort of propensity to social distance? I'm not sure of the data source in detail, so I'm not sure what's in there, but it looked like it was basically a population density measure more than an actual social distance measure.
Great, thank you for asking that question. So you're kind of wondering whether or not the degree of social distancing is indicative of population density rather than behavior?
Correct.
Correct, okay. Yeah, so we've looked at other measures of and included that in the model as well for population density. So we have a measure, it's called county type, and that is the proximity to a metro area. And so that variable was not listed in our top 10 of most correlated variables, and therefore was not included in our model, which we were somewhat surprised to see. So it appears that the Pandemic Vulnerability Index, that is the CDC data source for the social distancing metric, that was actually independent of just the population size or the county type.
Okay, thank you.
Hi, it's Michael Jones. I have a question. Serena, Emily, and Kellen, first of all, wonderful job. Congratulations on project well done. I'm curious if you could change one thing about your approach, what would it be? And why do you think that that would have a better impact or give you some additional information that you don't have right now?
I would have loved to have zip code level data, because I think our initial hunch was that we've seen these news stories where different racial and ethnic groups are not being vaccinated at rates commensurate with both their population and with the amount of COVID burden that they took on. And so I think that information isn't quite captured by the county level statistics. And so, one locale that has that type of data is Chicago. They have zip code level data for their vaccinations as well as their COVID caseload. And so it'd be interesting to take these methods and apply it to some place that has that granularity of data.
Thank you.
So I was just wondering about sorry, I was going to ask about the community-based vaccination programs that you were suggesting as a possible solution. How do you think that those might help with racial disparities we're seeing in vaccination rates? Because are those, you talked about a couple things. One is access, but another one that's very possible is what you call vaccination hesitancy. So I'm just wondering your thoughts on the impact of these little pop-ups in various communities. Do you think they can make a difference?
Certainly, I can speak to that. So there's a lot of on-the-ground anecdotal evidence that these pop-up events are working really well. And I think an example that's really relevant and local is the Hmong Village Community Center out in St. Paul actually have a really robust partnership with the pharmacy there. And so they've been establishing these pop-up vaccination events where they're mass vaccinating Hmong community members who are primarily seniors, right? And so they have really high turnouts and have really robust follow-up. And so these community-based vax programs, I think, are one of the best intentional approaches to really reaching those disparate groups.
Thanks for the information and really great presentation, everyone.
Thank you for your question, Mark.
So I have a quick question. This is Nick. A very provider-centric view I bring to this probably. Did you consider all hospitals the same? Be it critical access, VA, tier, quaternary, do you consider them all the same in your data work?
Yeah, I can talk to that a little bit. We were given really a whole suite of metrics from one of the required or one of the optional data sources for the competition. And some of those measures included not only just the number of hospitals per county, but also the number of beds that are inpatient beds that are available, the beds that are occupied by county or by COVID patients, number of ventilators. We had kind of quite a bit of information that allowed us to have more of a better overall view of what the county's level of resources was.
The only reason why I asked that question is rural hospitals are an incredibly different world than any sort of other, medium-sized hospital. And so they're just kind of treated differently. And so what I was thinking as you presented here is, so I've been vaccinated because I work for a care provider. A hospital equals healthcare workers equals vaccinations. And so I was curious particularly as well, just another thought of how we think about this differently is the VA. So the VA has a very particular demographic of patients they treat, many of which qualify as under 1B. And there's only, I think, one of them in the state. So I just think it's, the way that Minnesota is so, the Twin Cities is so dense comparatively, it makes it kind of interesting. So I was very intrigued by some of your findings around the nearby suburbs outside of Hennepin and Ramsey, to be honest. But this is really, really interesting. Very good work.
Yeah, that's really interesting too, because a lot of those veterans that are kind of living in those peri-urban counties, the vaccination that they receive would probably happen within Ramsey, which could, definitely have an impact on our findings there.
Thank you,
Great
Team
work, Joe.
1.
Very cool.
For the interest of time, we're going to thank Team 1 and move on to Team 6 for their presentation. Great job, Team 1. Thanks for joining this event. All right, Team 6, if you would like to share your screen.
Hi. Yeah, so finished sharing the screen. I'm going to start introducing our team. You see we see the other view. Okay, maybe you just have to switch it, please.
Yeah, so we currently see your presentation as well. Anna?
Yeah. Yeah, okay,
Perfect.
good.
You're good.
You hear me fine? Good. So thank you for having us. And we are Team 6. It's 4 of us. My name is Anna, and there's also Eric, Bupi, and Finn. We are the 3 of us, me, Eric, and Finn are from the Carson School of Management, and there's Bupi from the Bioinformatics and Computational Biology Department. And we decided to assess and study the effect of lifting mask mandates. And one of the reasons why we picked this project, this topic, is because we are hoping to shed some light on this kind of decisions and hopefully have an impact on this very critical decision making that is still happening these days of the pandemic. The good news is that, as you know, as everybody can see, that the number of cases all over the country is decreasing, and this is a great result of a lot of different factors, and certainly the vaccination is one of them. But also, like, this decreasing trend is kind of driving some decision making in terms of policies that we are questioning and wondering how much is based on data. So this is really what we're gonna explore today. We saw that some states, starting in February, started basically really lifting their mask mandates, lifting their restrictions despite some warnings from health officials. So, for example, Montana, early February, lifted the mask mandate statewide, and then Mississippi followed, followed by Iowa, and then Texas. So we're questioning, and a lot of news are also questioning, why are they dropping this mask mandate, and what is the data behind this kind of decisions? So we are really interested in understanding what is the effect of doing this, of this policy change in the states that have lifted their mask mandate on the development of new cases of COVID-19. And we're using the variable of COVID-19 cases per 100,000 inhabitants. But more specifically, we're looking at what's the effect now in spring 2021. And because you may wonder that what you would expect from what happened last year would be an increase in cases when you have when you lift the mask mandates. Indeed, for example, Mississippi in October lifted their mask mandate and they got a spike in cases. Similarly, Kansas left the decision up to the counties to basically opt in or out of implementing a mask mandate. The counties who did implement the mask mandate saw a decrease in number of cases, while the counties that didn't saw a very significant increase. So state officials say that actually the situation right now in spring 2021 is completely different than fall 2020. And they would expect that because of the vaccination and the general downward trend, then the effect of doing this kind of policy changes would be different. So we are interested in understanding if that is true, and that is what the data is suggesting us specifically in this case of spring 2021. So we started from looking at what we call a very naive analysis of the cases. We are looking at the case of Iowa, for example, and if you see in this graph, you see that the trend seems decreasing in the number of cases per 100,000 inhabitants in Iowa compared to the US average. And you see that they're both trending downwards, so they're both decreasing, but it seems that the gap is reducing. And you can see that this red line basically indicates the time of the lifting of the mask mandate. And you may argue that there is a shrinking of this gap that happens after that policy change, but you may wonder if some of this shrinking was already happening before the change. So a simple comparison of the number of cases per 100K is not going to reveal the effect of this policy change. So we thought about going deeper into finding more insights on this kind of inference. We really want to see, ideally, you know, we would, in an ideal world, we would have Iowa not do the lifting of the mask mandate and see what happens. But in reality, Iowa lifted their mask mandate in February, and it was a statewide decision. And we can kind of find a way to compare that to the states that fortunately still we have in terms of comparison, because other states, where there are currently 33 states who did not lift their mask mandate. And what we're going to do, and Finn is going to tell you more about this in details, is that we created a synthetic control based on a weighted average of the other states that did not lift the mask mandate. So the states that are in the control group, to compare what the real Iowa saw happening with the synthetic Iowa that Finn is going to explain in the following slides.
Yes. So for a short deep dive into the method, for those of you who are not familiar with it, the synthetic control estimator was developed in 2003. And what it does is essentially to create a pre-treatment control unit that is artificial or synthetic, that matches the pre-treatment trend of the treatment unit, in this case, Iowa. And then we can argue that any deviations post-treatment are a difference that can be seen as a causal effect. So we have an example of the passing of a tobacco law in California in 1999. And here you see the US average and the California average of tobacco sales. And the left-hand picture is similar to what you saw in the case trend. We see that after passage of the law, you have a bigger gap than before. But there's good reason to argue that, well, even before passage of the law, there was a trend that kind of separated the two. So what the synthetic control estimator does, it creates a synthetic control unit, which is essentially a weighted average of all units that are possible control units, that closely matches the pre-treatment trend, as you can see here. So then we can argue that any deviations post-treatment are actually causal to the change in policy. For the COVID case, we are looking at the cases per 100,000 inhabitants within the last 7 days. Our predictor variables are a 14 days lag of those cases, the ratio of past infections, so how many people in a state were already infected and have some sort of immunity. what is the vaccine development in the state? So immunization is the number of people who got their first shot of a vaccine. What is the population density? We have from the COVID-CAST survey an indicator of how many people are wearing masks. Not self-reported, but reporting of how many others are wearing masks. We have an indicator of how many restaurants are visited as kind of an indicator of how active are people. And we have a suite of mobility stats from the Google Community Mobility Report that measured pre-COVID mobility versus the mobility during COVID. Based on those predictors, we create a synthetic Iowa, which is a weighted average that consists of 87% Wisconsin, 11.5% Alabama, and then there is a range of other states with really marginal percentages. So the algorithm created this kind of synthetic Iowa as a weighted average to closely match the pre-treatment trend of Iowa. Now we have Wisconsin and Alabama as kind of our main drivers of this pre-treatment of this synthetic Iowa. So if Wisconsin or Alabama had introduced any policy measures that had any effect on mask wearing or on COVID cases within the time frame of the analysis, then we would have the problem that we are not only measuring the causal effect of Iowa lifting their mask mandate, but also of those other policy changes. So we looked at Wisconsin, who on 3rd of February ended the emergency order by the Republican-controlled legislature, but on the same day, the governor re-signed a new emergency order. So there was no actual policy change because everything happened within a couple of hours. And there was no policy change in Alabama within our study period. So this source of bias can be excluded. When we look at the trend of Iowa, here the solid line, and the synthetic Iowa, here the dotted line, we see that pre-treatment, so pre-red bar, we have a close match. So our synthetic control unit seems to closely follow the trend of Iowa. But what happens is that roughly 6 days after the mask mandate is lifted, the real Iowa begins to deviate from the expected trend based on the synthetic control unit. This deviation continues until the end of the data that we looked at. If we now take this and map the differences, we get this plot. So pre-treatment, the differences kind of deviate plus minus 0. After treatment, the differences are highly positive. In fact, after 2 weeks, we see a 25% increase in cases in the real Iowa compared to the expected development of cases in the synthetic Iowa. One limitation here is that in the community profile reports that we used, the pre-treatment period is fairly short. So ideally, we would use many months of pre-treatment period to be able to limit unobserved heterogeneity. But because of availability of vaccination data and also kind of the dynamic of the COVID pandemic, the pre-treatment period is fairly short. If one now takes the mean squared prediction error, so the squared sum of the sum of squared deviations pre and post-treatment, one can calculate a ratio, the so-called post-pre MSPE ratio. This ratio can then be used to help us decide, well, is this a result that we are likely to get by chance, or is this a result that is actually a causal effect that we're seeing here? And the way we're doing is is we are taking all 33 control states, those states that still have a mask mandate in place, and we do as if those states lifted their mask mandate on the 7th of February. So what we would expect is, because they in fact did not lift their mask mandate, we don't see any deviation post and pre-treatment. And in fact, if we are doing that and calculate the post-pre MSPE ratio, we see that Iowa has the second highest post-pre MSPE ratio. Only Nevada has a lot higher, and then we looked at Nevada, and Nevada actually had a steep drop in cases just in that period that we looked at. So there was no increase, but there was a drop in cases. So Iowa and Nevada are kind of outliers from the data. So based on this, we can say that the chance of obtaining our results purely by chance is 5.8%. So the probability that those results, Iowa having kind of an increase in cases, to obtain that by chance is fairly low given a sample size of 34, so a fairly limited sample size. We then continue to look at the mechanism. So if the policy change, so the lifting of the mask mandate, has an effect on the case development, then there are potentially two mechanisms. One mechanism would be that people, because the governor lifts the mask mandate, become more active. We are going out more, we are meeting other people, and because they are meeting other people, the number of COVID cases increases. The other mechanism is, because the governor lifts the mask mandate, people stop wearing masks, and given the activity that they have, that leads to an increase in infections. Then there are other factors that also will influence the cases, but that we don't see as a mechanism of lifting a mask mandate. When we look at how Iowans stayed at home, so this is now from the Google Community Mobility Reports, same analysis, synthetic Iowa versus real Iowa, but mapping kind of how much did they spend at home versus the pre-COVID baseline. We see that there's a general downward trend, but we don't really see a difference between Iowa and the synthetic control unit. So this trend of being a little bit more active is what we see everywhere in the US. And that can't be the reason why suddenly cases increased in Iowa. If we look at reported mask wearing, on the other hand, we see pretty clearly that after the mask mandate is lifted, the real Iowa suddenly has a lot less reported mask wearing of others compared to the synthetic Iowa. So this is kind of further proof that the mechanism by which lifting the mask mandate infects cases is actually through people are wearing less masks. What can be done about it? We fully understand that people are longing to return to normal. And we also understand that governors and county officials want to reopen their counties or states without risking lives. We mentioned earlier, there is a case to be made that immunization, downward trend in cases might lead to a different result of lifting mask mandates. But what we see in the data is that lifting mask mandates, even though we have immunization on the way, leads to an increase in cases. And we also see that the mechanism clearly seems to be that people stop wearing masks if a mask mandate is lifted. So governors saying, well, I trust my people to continue wearing masks, I will wear a mask myself, does not seem to work as well as they believe. The path of increased activity, while it also is declining, that is a kind of statewide, nationwide trend. So our recommendation, given that people want to return to normal and governors want to slowly reopen their communities, is that any reopening policy should focus on mobility and not on lifting mask mandates. We also understand that this will probably not influence states that already lifted their mask mandate, because as the saying goes, you can't reason somebody out of something that they haven't reasoned themselves into. But we hope that this can inform policy decisions in those states that still have a mask mandate in place, that are thinking about how can we safely keep continuing to reopen the country. In conclusion, a simple comparison of averages does not work to tease out a causal effect of lifting a mask mandate versus cases of COVID. The synthetic control estimator gets us closer to estimate a causal effect. In fact, we find that within 14 days of lifting a mask mandate in Iowa, there was a 25% increase in cases compared to the expected number of cases. And the probability of obtaining this result by chance is as low as 5.8%. So we really urge any policymakers, decision makers to focus on mobility while reopening and keep mask mandates in place. And we hope that our analysis can contribute to some of those decision processes and help to safely return to a new normal, however that will look like in the future. Attached references for your convenience, and stay safe, everybody.
Thank you, Finn. Okay, our judges, we have 5 minutes to ask questions for Team 6.
Great presentation. When you look at the difference between population densities throughout the state, when you were coming up with the synthetic Iowa, how does the density of the population come into effect?
So some say the beauty of this estimator is that the researcher, in this case we, is kind of hands-off. We supply the algorithm, the range of predictors, and the algorithm figures out the best weight for each of those predictors and for each state to create a pre-treatment trend that is as close as possible. So there is less choice of the researcher to influence the results. The only choice we have is what variables we put in, and then the algorithm is matching kind of a close pre-treatment trend as possible. So essentially minimizing the mean squared prediction error pre-treatment.
Thank you.
18.6, good job. Curious if you guys talked about or thought about including household economic data in your analysis, and if you did, I'd like to hear about that and why it wasn't included.
What can you give us an example of what kind of data you mean?
Household economic data. So when you think about
okay.
the stratification of income with certain households and how that data might correlate with the wearing of masks or not wearing of masks once a decision was made.
Yeah. So the reason we kind of stayed away from those topics is one, data availability, being limited to only publicly available data. So we looked at in a robustness study on politics, so election results in the last election that did not change our data. And also, we think we are looking at the outcome or the mechanism by including how many people are wearing masks, how active are people. And we are looking at that pre-treatment. So any of those household economics and also political factors are represented in the pre-treatment trend in mask wearing and the pre-treatment trend in mobility. So by including that mechanism, we kind of get around to include those kinds of data.
Thank you.
basically like those would not have changed because of the treatment, because of the policy decision. They would be included in the before treatment data and the after treatment data.
I have a question. This is Pam. I'm wondering how your approach could help for a governor who's trying to decide when it is okay to lift the mask mandate, because that probably won't go on forever. And I get that you prioritize activity over masking, but how can your approach help to decide where that sweet spot is, where it's safe to lift a mask mandate?
I think what our approach shows is there's a strong causal effect of lifting a mask mandate to cases. And that my personal opinion is I'm really happy to wear masks every winter for the rest of my life, shopping and transit. So our analysis currently is only looking at kind of the past data. And given that, I don't see how that can help to really say lift the mask mandate. What we potentially can do now that Texas opened on the 16th of March, so we are about that time now where we would see an effect in Texas. And we could run that, and maybe in Texas it's different now because we have more vaccination coming in. Personally, I don't believe that. I think we will see the same effect if we run the same analysis next week on Texas. But that is kind of what we can do. We can look at past interventions and see how they turned out and then say, well, better not do it right now.
And also as the vaccination rolls out, it's also that this trend, the number of cases is decreasing, but it's not stable yet. So once that number of cases will be stable at a very low controllable range, I think we could consider this kind of decisions again based on the data of that time. Right now, it seemed that this state did it a little too early.
Yeah, so great job.
Question maybe, sorry.
Oh,
maybe
go ahead.
One more judge question.
I'm happy to go ahead. What I'm wondering is the predictive value of this. So you guys did, I think, a great job analyzing this. I'm wondering if there's a way to extrapolate from this data to see how compliance to mask mandates might impact the data, because we know in many communities the compliance rates were fairly low. So what if we had both mask mandates but also enforcement of them? Could we do a prediction of how that would impact the number of cases?
Not given this estimator, because we are not getting, like you would get in a normal regression, any coefficients on the data. We are looking at average values. But certainly with the same kind of data set and some sort of matching estimator, we could then do a normal ordinary least square regression to get coefficient on the effect of mask wearing. However, I'm more convinced of the actual causal effect using this estimator than any regression. That's why we chose to use this estimator at this point in time. Thank you for your question.
Well, thank you so much. Again, in the interest of keeping time, I know there are so many questions we want to ask each team, and I'm sure the audience, and I apologize to the audience as well, because we're limited in time. We move to team 23. Thank you, team 23, and thank you, team 6.
Hi, this is Team 23's presentation. My name is Delaney Anderson. I am a Master's of Public Health student in Maternal and Child Health.
Hi, my name is Arnold Johnson. I am a PhD student in the School of Statistics here at the U.
My name is Carissa Dock, and I'm a medical student at the U of M.
And my name is Max Traub, and I'm a Business Analytics Master's student at the Carlson School.
And today we are going to be talking about the community severity of COVID-19 in Minnesota. So starting from the beginning, we really wanted to identify and quantify how different socioeconomic factors at the community level would be affecting the duration and severity of COVID-19 in communities. And so to do this, we decided to use two data sets, the Community 19 hospital capacity and facility data set, as well as information from the 2019 American Community Survey data, which included values from the Socioeconomic Vulnerability Index. And so we wanted to do this because when we're talking about the COVID-19 pandemic, right, if we look at things from just a state level, there's going to be a lot of variation at the communities, right? If we try to say, well, this is a one size thing that fits all, that's not going to be able to adequately answer the nuances of different communities in Minnesota. And when we talk specifically about how we are going to allocate resources, how we are going to make sure vaccines are being provided to different areas, where we're going to have healthcare workers, right? How stressed a hospital is in regards to capacity. If we go too large, such as we found at the state or the county level, we aren't going to be able to answer that. And so we wanted to investigate this specifically using a community size, and I'll define what we are talking about when we say community, because we wanted to know and be able to start quantifying these relationships for potentially future pandemic responses. Most of our public health staff at the university are recommending that another pandemic will probably happen, if not in our lifetimes, in a similar type of range to the 1918 pandemic. And so it's important that we can quantify what this looks like for Minnesota specifically, so we can answer and provide guidance when it comes to those decisions. So some definitions that are going to be important for our presentation today specifically are going to be our outcome variable, which we called the COVID-19 hospitalization rate. And we decided to do this based off of the cumulative sums of these measures, the cumulative values for each hospital, how many hospitalizations, and so beds being taken up are by confirmed or suspected COVID-19 patients divided by the cumulative measures of adult hospital beds for each hospital. We wanted to do this to be able to avoid any potential biases or confounding by events happening at a certain time point, right? If we measured something only by a week. And so by adding this all together, we thought that this would give a better sum for us of what the total severity of the COVID-19 pandemic looked like in these different communities. And so our definition of a community is we decided to use what's called a hospital service area, defined by the Dartmouth Atlas of Healthcare project, as a combination of zip codes that are where its community members are more likely to get their hospitalizations in that area. So to visualize this, one of our members created a map that, if you can see each of the blue areas outlined by a brown spot, each of the blue areas outlined by brown lines is a hospital service area, and each of the brown dots inside of them are a hospital. So already just looking at this visually, we can see that in the northern part of the state, there's much fewer hospitals. And so that's something that we wanted to take into consideration when we actually plotted our outcome variable. So our outcome variable, as we just said, is basically the percentage of a hospital cumulatively that their hospitalizations are being caused by COVID-19, either confirmed or suspected. And so when we look here, we're able to see that the worst areas here, as the orange or the red, in case our key is a little small across the internet, is based in space. Which makes sense, right? We're talking about COVID-19, a contagious disease. So it makes sense that areas where they're having a worse outbreak and therefore more hospitalizations are going to be closer to each other. And so one of our other members, Arnold, is going to talk more specifically about how we took space and relationship to space into consideration for our model. And so our model, the exciting part, what are we going to use to predict this? We decided to use 7 variables, and the decisions for what to include and what to not include when we look at all of the wonderful public data we had available was really content area knowledge. And we wanted to come at this from a health equity lens. We wanted to think about what are really going to be factors that are going to be causing people to be experiencing COVID-19 at a worse rate or at a worse value that they need to be hospitalized, right? We're not just talking about confirmed COVID-19 cases. We're talking about people who actually have to be hospitalized and take up a bed, which is going to be taking up resources at a hospital, right? Because in the pandemic, people who break their arms or people who have a car accident aren't stopping. Those things are still happening at the community, and now there's a pandemic on top of that. So the 7 variables we chose to include, we didn't try, we did. Our first one was talking about commuting to work, right? If I can commute to my job, which usually takes sometimes an extended period of time, if I can do that individually, meaning in my own car, I'm not going to be exposed to somebody like I would be if I was on a bus or on a tram or on a subway for an extended period of time, which means there's less chance of transmission. We also wanted to include the percentage of these hospital service areas that had housing structures that consisted of greater than 10 units. So that's talking more about apartment buildings and condos, because again, it's the idea that if these people are in closer proximity for longer periods of time, that gives more chance for an increased risk of transmission. When we talk about equity, we also have to realize that there's a severe shortage and issues with how we allocate things both in the state and in this country. And so we wanted to include really factors that are going to affect how people are getting healthcare and how they're accessing it. And so that's why we chose to also include low income, which we defined as households earning less than $25,000 a year, because specifically low income individuals are also less likely to have insurance, and that might affect at what point they receive care, which might result in more hospitalizations, right? If they're not getting treated as earlier for their symptoms, they might be more likely to be having worse symptoms. We also wanted to include the age element, and we chose to both include children, right, kindergarten to age 12, or not age 12, to grade 12, and then the elderly, those greater than 65 plus, because the relationship we already know that exists among the elderly, we wanted to see how that was affecting hospitalizations from COVID. And we also wanted to investigate how school-aged children and the percentage of communities that were school-aged children was going to affect this, right? Because there's a lot of things in the air currently about, are we reopening? Is it safe to reopen? What does this look like? How is this going to affect really our community health? And then because unfortunately, we don't have a variable for systemic racism besides the fact of people's race, we chose to include those because we wanted to take into consideration the historical trauma and the issues that communities who are predominantly minorities may experience in barriers to receiving and accessing healthcare. So with all of our variables, we wanted to plot a few of them just to kind of get a preemptive look. And so this is in comparison to, or you want to think about it and compare it to that earlier graph I showed you with the orange and the red showing our outcome variable. This graph specifically is showing the hospital service areas by their percentage of Hispanic or Latina identity. So we can again see that this is more predominantly in the southern part of the state. Another variable we chose to visualize was the percentage of each household hospital service area that was greater than 10 units. This one, unsurprisingly, is a little more clustered based off of the Twin Cities, which makes sense. And so I also wanted to highlight, I realized I forgot to say it earlier, when we're looking at this graph, there's some missing data, right? You see that these hospital service areas in white aren't providing us information, and that's for a few reasons. Either their hospital, that area is either an Indian reservation, a state or national park, which obviously won't have people or a hospital in it. And we don't have information for the Indian reservations. Some of the more southern ones, either the majority of people inside of them aren't receiving care at that hospital or are not receiving care inside the state. So to explain more about the model is going to be Arnold.
Great. Thank you, Delaney, for sort of introducing our thought process and how we approach this problem, and also giving us some nice initial visualizations that we use to get a feel for how these different variables were distributed over the geography, in this case, the state of Minnesota, and hopefully gave you that kind of feel too. As Delaney noted, you can get a kind of idea for possible relationships by comparing the geographic trends across maps. But at the end of the day, that's a little bit ad hoc. It's a visual technique, so it's sensitive to scaling. If you want to be more rigorous about sort of quantifying and digging into these relationships, you should turn to a statistical model, which is what we're going to discuss now. Specifically from the beginning, we focused in on linear models for quite a few reasons. They're very simple to implement. Importantly, they're easy to explain to practitioners in terms of, like what they mean and what they're doing, compared to more complex methods. And at the end, you get interpretable coefficients, which can allow you to not just decide if there's a significant relationship between variables, but actually quantify the degree of that relationship, which can be absolutely crucial in practice. However, there are some modifications we have to make. Specifically, a straight ahead linear model assumes independence between your observations. In our data set, the observations are hospitals with sort of associated data from the hospital service area. And as Delaney already mentioned, there's a strong spatial structure to this data, and so that independence just isn't going to hold. So we replace that independent assumption with a generalized least squares with spatial correlations framework, which might sound intimidating, but it's actually quite intuitive in this context. We just assume that the correlation between any two hospitals is a function of the physical distance between them. Okay, again, sort of very intuitive thing about the spread of infectious disease and outbreaks during a pandemic. The other modification we made, just to aid you in interpreting this table of coefficients, we implemented a Bonferroni multiple testing correction. When you're looking at a bunch of p-values like this in a table, you're testing 7 statistical hypotheses at once, which can inflate your type 1 error rate if you're not careful to adjust for multiple testing. That's obviously a bit of a technical point that we could get into more in the Q&A if people are interested. But what it means for interpreting this table is we use a more stringent rejection threshold for the p-values of 0.007 rather than the conventional 0.05. Applying that analysis, what we find is that the only truly significant variable that pops out is the K through 12 variable that Delaney defined before. And however, we also identified the percentage of Hispanic or Latino people in the corresponding hospital service area as being an effect of interest, because after all, this is an exploratory analysis. We envision this as being sort of very early on in this iterative process of science. I think would be sort of a mistake to try to do too much or try to make this the analysis to end all analyses or assume that we have the perfect model which perfectly describes the system, okay? What we're doing is we're identifying relationships that are of interest in sort of subsequent, more rigorous studies. And in this case, we observe a positive relationship between this proportion of Hispanic or Latino people and higher rates of hospitalization, which is obviously of grave concern when it comes to health equity, which, like Delaney mentioned, was sort of our motivating approach to looking at this data. So even though it's not significant in the sort of strict binary sense, this is an exploratory analysis. We don't have to be that dogmatic. And so again, we recommend that any further analysis of sort of community level COVID severity in the state of Minnesota should take these two variables into account. If you go to the next slide, you can see an example of what I mentioned before about how a simple linear model like this allows you to draw conclusions about effect size and not just effect significance. So you have to be a little bit delicate with your wording here to, again, avoid overstating your conclusions or saying something your model doesn't support. But what you can be explicit about is this idea of association. So while controlling for the other variables in our model, a percentage point increase in this K through 12 population is associated with an average decrease in the cumulative COVID-19 hospitalization rate of 0.6 percentage points, okay? So again, this is what a sort of linear model-based analysis can get you. And of course, there are interesting discussions to be had about the implications of this specific coefficient. And we had those interesting conversations with our masters of public health and our med student. But we also kind of ran into some existential problems with our data, which almost renders the model output moot. And we'll talk about that in a second. So again, so we don't need to spend time on the specific implications of this. Like I said, I say we ran into limitations, but in fact, we went looking for them after the almost disappointing results in the previous slide. Like Delaney said when she talked about motivating the choice of predictor variables, those were based on, again, our sort of subject area knowledge of our sort of the people in the group who work in this field, and we were surprised to see almost no significant effects. So we have this sort of conflict between the subject area knowledge and what the data is telling us, or put another way, the conflict between what the data is telling us and what we think it should be telling us. So if you go to the next slide, you can see an example of where this breaks down. So just to back up again, we started with hospitalization data because based on the discussions during the kickoff event, we felt that they were the most relevant and the most reliable indicators of community level COVID severity. If the hospitals are overflowing, that's obviously bad news for the reasons that Delaney was Delaney was outlining. And if you start with that hospital by hospital aggregated data that comes to us from the Department of Health and Human Services, these hospital service areas are the most reasonable geography, right? This is our best idea of the demographics which are feeding into those hospitalizations. However, the HSAs are in and of themselves very limited, and I present as a kind of case study this hospital service area in the middle of that map. These thick black lines are denoting hospital service area. The orange is just like highways, I think, don't pay attention to those. You know, the thing in the middle outlined by the black lines is a single hospital service area, which is connected to a handful of hospitals in the Minneapolis area, which you really can't take apart using that HSA definition about, you know, sort of zip codes where people get the majority of their hospitalizations from that corresponding hospital. And so what you end up with is this enormous geographic unit, which is covering, you know, downtown, the university, South Minneapolis, Northeast Minneapolis, Richfield, the South suburbs, even some northern suburbs, which don't even make it on the map. You're losing communities in this unit of analysis. This is a case where the big data is too big. And there's no way you're going to be able to look at this kind of unit and, again, burrow down into the communities at the level we want, even though, again, as I just justified, this is really the most reasonable geography for the HHS hospitalization data. So yeah, so you end up sort of stuck and you have to rethink things, and that's what Carissa will talk about next.
Thanks, Arnold, for just showing that graphic. And as Arnold was highlighting, we basically came to the conclusion that using a hospital service area, because of its size, is just essentially a poor way to correlate the socioeconomic factors of a community with that impact on their COVID-19 hospitalization rate. For example, the city of Minneapolis has more than 43 different zip codes. And so it's really difficult to separate the very racially and economically diverse populations that exist in our community without looking at a smaller level. So our proposal to this solution was to partner with hospitals directly and use more patient level data to tie their hospitalizations to smaller communities. And then apply a very similar analysis, but with the hopes of extracting more meaningful results relating to how socioeconomic factors are affecting COVID-19 hospitalizations. One thing that we thought would also be helpful is that using a smaller region like the zip code of a patient in a hospital is that it would eliminate the issue of patients being transported into a different hospital or a different hospital service area, as we were seeing in states like Texas and New York in the heat of the pandemic due to overcrowding and inadequate resources. And so how do we actually implement this idea? So the zip codes of patients are recorded when they're admitted to the hospital. However, any digits beyond the first 3 numbers of the zip code are protected under HIPAA. Therefore, like adding this extension to our project would require an IRB approval, but we think it would be reasonable and worthwhile to go through this extra hoop to extract this data and hopefully provide more meaningful connections relating to how socioeconomic factors are affecting COVID-19 hospitalizations in our state and across the United States. We also are interested in looking into different ways to consider the impacts of COVID-19 on Indian reservations, as well as unhoused people in the community, as both of these populations are currently excluded from the data that we have access to, but are clearly very important members of our communities and important people in transmitting and preventing disease. And so I guess now we can go, I think we have our references, and then, yeah, we can open up for questions.
Thank you.
I have a question, and I appreciate the ultimate conclusion around the HSAs. But I'm interested in hearing a little more from you about you spent some time discussing the variables that you wanted to include in the model. Can you talk a little bit about the variables you excluded? I mean, you had 7 predictors in the model. There were lots of other things you could have considered. What was the thought process? And by the way, I should say thank you for your presentation. Sorry, I'd like to dove right in. Talk a little bit about the trade-offs you made in terms of the kind of the a priori model that you were building.
Yeah, I can talk a bit about that. we had to really balance, right? The idea of when you're making a model, if you include too many variables, your model becomes useless. And if you include too few, it's not going to be good enough. And so we really wanted to focus on what we had access to. And so a lot of these talking about like the percentages that came from the social vulnerability index that the CDC defines as these are variables that people who have, or communities that have higher percentages of people with these demographics, right? Low income, higher multi-housing facilities, all of those things are going to have worse health outcomes. And so when we've been talking about the COVID-19 pandemic, that's also occurring alongside the systemic racism pandemic happening in our country, the realization of what's going on, we really wanted to talk about kind of these hot button issues of people are talking about these things at the same time. How do they relate? When we're talking about how terrible this pandemic is, and one way to look at that is how overrun is a hospital and how stressed is a hospital trying to take care of its community members, how do these things play into that? And so I don't remember why we settled on 7 instead of 6 or 8. Maybe Arnold might have something to say about that, but I think we were looking at all of these and we felt that these were going to represent a wide enough distribution and encompassing of somebody who might be struggling financially or struggling with their health or struggling to handle things regarding exposure during the pandemic. I don't know if any of my team members wanted to add in anything else we chose.
Thank you.
A statistics professor I once had said that model building is mostly arts and crafts. So, we have these, group discussions, we think about what would be interesting to look at, what we think might be predictive. But I mean, certainly if, like our judges got together and decided on variables to build a model, there might be some overlap, there might be some things that they choose to look at that we didn't. But at the end of the day, again, you don't need to come up with the model to end all models. You can look at a sort of subset of things that you find interesting, and there will be other studies, there will be other projects to look at different aspects of this obviously very complex system. You couldn't possibly include every variable that's predictive here. So, maybe that's a bit of a vague answer, but yeah, we sort of talked about this ad nauseum and settled on these as ones that we all agreed on were both interesting to look at and likely to be predictive.
Thank you.
I have a quick question, really quickly. So do HSAs account for services provided? So a hospital in Kennebec County doesn't offer the services in Ramsey County. Does it consider those hospitals equal no matter what?
Yeah, that's a good question. I don't think so, because in the end it has to be a partition, so it's yeah. So
one thing I was kind of
like you get your emergency hospitalizations here, but then to get this service you have to go to the big one in the city. Like I don't think that's accounted for in the definition.
And where I was going and why HSA kind of throws a wrench is because COVID was so novel and quite serious, still is, of course. I'll speak for us. We have an aggregation plan. We hospitalize at one location, even though we have hospitals all over the state. And so I was just curious, the HSA, it's a solution that may be the best option, but it kind of is a little misleading because of how hub and spoke care delivery works. But really cool. This is a very cool. I was very surprised to see that variable was correlated, to be honest. I did not expect that.
Yeah, and that was part of like the variable decisions of just, we wanted to see, well, what is actually related? Because this is also important if it's not.
Great work, thank you.
Do we have one more judge question? All right. Well, thank you so much, Team 23. And now we're on to Team 18.
Hello, everyone. We are Team 18. My name is Sam. I'm a pharmacist and a PhD student in the Social and Administrative Pharmacy program from College of Pharmacy.
I'm Ying, and I'm a first-year PhD student at the Institute of Health Informatics. Thank you for having us.
And my name is Hez, a PhD Translational Bioinformatics candidate from the Institute for Health Informatics.
So our topic today is racial health disparity in COVID-19 case fatality rate. There are two studies recently published that show during the COVID-19 pandemic, the Black people and community were affected as twice as its proportion in overall population, such as COVID-19 case numbers. However, there's a conflicting data for COVID-19 death. The article on the left, published by New England Journal of Medicine, they didn't find Black is an independent risk factor for COVID-19 death. But the article on the right, published by Annals of Epidemiology, their results suggest that community with high percentage of Black residents are at higher risk of COVID-19 death. So in order to investigate this essential but conflicting issue and to mitigate the racial health disparity during COVID-19, we decided to look into how COVID-19 deaths are affected by races and other factors. So how do we start? This is a conceptual diagram that race can affect COVID-19 deaths. Unlike most articles using either cumulative COVID-19 death numbers or cumulative COVID-19 case numbers, we decided to use case fatality rate, CFR, as our main outcome. The reason is that CFR can reflect severity of COVID-19, and the death normalized by case numbers help us to compare apples to apples across different populations. From data's perspective, it's also beneficial to just use one model to predict one outcome instead of one model to predict two outcomes. But there are more factors behind races when we want to investigate CFR across populations. As you can see, there are many factors surrounding this diagram that can also contribute to the association between races and CFR. So we decided to use different approaches, including an epidemiologic approach to find the risk factor for CFR, and also the data scientist approach to predict CFR. Here's our data analysis plan. We use COVID-19 community profile and policy files from HHS to get county data in 2021. We also linked our data to MIT presidential election data and CMS data to have more information on 2020 president voting and comorbidities at county level. There are three parts of our analysis. Part one is descriptive analysis. We compared the distribution and frequency of many factors by high percent of Black versus low percent of Black at counties level. In part two, after data cleaning and replacing the missing value with weighted average, we created a multivariable Poisson regression model to identify the risk factors for CFR and to measure the incident rate ratio IRR of CFR for different factors. Part three is a prediction model. We forecast 5 moving variables by Auto-Regressive integrated moving average, ARIMA, and build multiple prediction models and select an optimal model through hypertuning based on coarse validation accuracy. The purpose of this is to use a machine learning algorithm to predict CFR for the next 30 days. Next, we will have In to present our descriptive analysis.
Thank you, Sam. We started with the COVID-19 community profile from the HHS department to investigate if we are seeing a higher trend for the Black communities. To assess the impact on Black communities with the county level data that we have, we have categorized each county into 2 categories, higher percent of Black or lower percent of Black, based on the distribution of African Americans. If the county has a percentage that's over 13%, the county is categorized as higher percent of Black, otherwise lower percent of Black. We have chosen a 13% threshold based on the average percentage of non-Hispanic Black across all counties in the United States. For all time series analysis, the duration is set at any time from last year 16th of December to this year 6th of March. Looking at the cumulative cases and deaths per 100,000, we agree with most of the existing papers that higher percent of Black community has higher COVID-19 cases and deaths. We know that throughout the start of the COVID-19 pandemic, the higher percent of Black community has suffered more. But what about at any point in time starting 16th of December last year? By looking at the area of concern continuum, the burden on both communities in our model has been decreasing over time. However, within the higher percent of Black community, there is a higher densities of counties categorized as hotspots or sustained hotspots, which indicates a higher burden on the community. We also plot the graph of case fatality rates over time for the 2 categories to assess the severity of COVID-19 virus. We find that even though the gap between the 2 categories are getting smaller, the higher percent of Black still has a higher case fatality rate over time. The next question that came to mind is, what is the trend of COVID-19 case fatality rate in other races? And is the trend going up in proportion to the percentage of Black within the community? And we find that as the percentage of Hispanic or white increases, the CFR trend stays roughly the same, that it is almost a flat line. We also notice a downward trend as the percentage of Asian and Native American increases. What about percent of Black? As the percentage of non-Hispanic Black in the community increases, we see an increase from 2% to 3%. But why? What are the factors that are contributing to this relationship that we're seeing here? With that in mind, we started exploring possible factors to investigate the racial health disparity in COVID-19 case fatality rate. First, we look at the race distribution between our two categories. For a higher percent of Black community, we have an average of 26% of Black. In the lower percent of Black community, we have 17% higher in white distribution, 1% higher in Asian distribution, 2% higher in Hispanic distribution, and roughly the same in the Native American distribution. Out of the 3,220 counties that we have population data for, 21% of them are categorized as higher percent of Black in our model. Higher percent of Black community also has a higher in poverty rate, uninsured rate, and more support for the Democrats. Using CMS chronic condition data in 2018, we also see that in the Medicare population, higher percent of Black community has higher prevalence in almost all categories of chronic conditions, including cancer, chronic kidney disease, COPD, mental health disorders, diabetes, heart diseases, and stroke. Then, the next question is, what about other metrics that are related to the COVID-19 pandemic? We started with the COVID-19 test capacity. We find that the testing capacity for both categories are roughly the same. The higher percent of Black is more consistent in the percent of tests resulting in 3 days. However, since the positivity rate is higher in recent months for the higher percent of Black community, it could also indicate that there are underreported cases that we have to keep in mind in our model. In terms of hospital capacity, we find that higher percent of Black community has higher inpatient beds, ICU beds, and ventilators. Getting the COVID-19 policy data from the HHS department, we look at their active policy in food and drink, mask, K-12 or childcare, entertainment, manufacturing, household worship, and shelter in place. Out of the 7 major categories, we only see a higher popularity in mask wearing order in a higher percent of Black. With the COVID-19 vaccination rolling out at the end of last year, we are also curious how each category does in terms of COVID-19 vaccination. Since we only have state-level vaccination data in the community profile, we outsourced to state and county departments and found county-level data for 19 states. So on the left is using state averages, and on the right, you see the county-level data for those 19 states. Based on the state averages, even though higher percent of Black has less vaccine distributed and administered, the gap is not significant. When we compare it by county, we see the gap slightly increases, especially when measuring the number of people who have been fully vaccinated. We have decided to use state average in our model as the county level data is not complete, but we keep this gap difference in mind when interpreting our model later. The next question that follows is, how can we measure the community acceptance of the COVID-19 vaccination? We first explored the full vaccination rates across each age category, and we find that they are slightly lower, but roughly the same between the two categories. But from the survey from Kaiser Family Foundation, we see that only 41% of Black adults have been already gotten the vaccination or will get it as soon as possible. When asked if they have already received the vaccine or any household member has been vaccinated, it is alarming that Black has lower percentage in the two categories. This proves that even though the vaccination rate does not differ much across states, but there is definitely a significant difference between the Black communities within each state that our data would not be able to capture. We should expect an over-reported vaccination rate in our higher percent of Black community, but we think the full vaccination rate will add value to our model as it is in sync with the survey. I'll now pass it back to Sam to discuss our risk factor model.
Thank you, Ian. Before we create a multivariable Poisson regression model to assess the effect of percent of Black to CFR and find other risk factors, we first checked the distribution of covariates across low and high % of Black. Since most results have been presented by Yin, this table is just for your additional information, and we'll go to the next slide. We also checked the distribution of covariates across high CFR versus low CFR. The threshold is 1.9%. And as you can see in the highlight area, compared to county with low CFR, the county with high CFR have higher uninsured rate, higher % of Black, more ICU or inpatient beds and ventilator used by COVID-19 patient in last 7 days, and less PCR testing per 100K in last 7 days. And overall, more comorbidities for the Medicare population. The outcome metrics is also higher in higher CFR counties and lower % of COVID-19 vaccination rate and flu shot rate, less voting for Democrats, and less active shelter-in-place order. This is our Poisson regression model to estimate the IRR of percentage of Black to CFR when adjusting different variables. As you can see from model 1 to model 7, when we add other covariates, the IRR of % of Black to CFR are pretty similar. Until model 8, when we adjusted comorbidities for Medicare population, the IRR decreased to 1.33, but overall, the Black percentage is still significant. The model used March data. We also run the same data with February and January's data set as a sensitivity analysis. We also run different regression models such as negative binomial or convert the CFR to categorical outcomes and run logistic regression models. Overall, we all got very similar results, which can support our finding from the Poisson regression model. So now let's go back to this diagram. Now we have a better understanding of what factors are also affecting CFR beside races. And we believe other factors are something we can address to mitigate the racial health disparity to COVID-19 CFR. For example, we found % of poverty and % of uninsured rate are also risk factor for high CFR, and more comorbidities in age population can also increase CFR at the county level. On the other hand, if the counties have more active mask wearing order and shelter-in-place order, or more flu or COVID-19 vaccination distributed and administered, it may decrease CFR at the county level. Now I'll pass over to Hez for our prediction model.
Thank you, Sam. And now we will dive into the flow of data analysis and prediction. So in the beginning, we start with the collection of raw data from multiple sources and daily dataset, which needs to be processed and cleaned to become a clean time series county data. We did the descriptive analysis and risk modeling investigation. Then we represented them visually, which we investigated and took into account for feature selection. We also used dimensionality reduction and published articles too to get to the subset clean data, which was ready for training and testing for forecasting model and for prediction model. For forecasting model, the forecasting model was needed to forecast 5 moving covariates, including vaccination, RT-PCR test, and inpatient beds factors. These became the inputs to the ARIMA model or Auto-Regressive integrated moving average that was hypertuned. The prediction model, extra trees regression, was fitted with the clean time series data starting from December until March 8th to predict CFR for each county. The extra trees regression model gave us a 99.7% cross-validation test means R-squared goodness of it. From the forecasting model, the 5 forecasted outputs became inputs to our fitted prediction model, extra trees regression. The other inputs were 64 covariates, which include demographics, hospital, policies, and comorbidities factors. They were assumed to be constant for each of the counties for the next 30 days. The predicted outcome was produced, and then we analyzed the predicted outcome with future March 15 validation data. And finally, we made a visual representation based on this prediction. So here's the result for the forecasted prediction for March 15th CFR. Our chosen prediction is extra trees regression model with hypertuned parameters. And now we can compare with the actual CFR. As you can see, visually, the CFR are not really different. Now, we can see them side by side. Statistically, using some regression scoring metrics, we get the following: R squared of 0.988 and relatively small mean errors. These metrics tell us that the prediction model does well when compared with the actual March 15 CFR. Finally, based on the predicted model, we get the CFR predicted for future April 7th. This map shows a very similar trend with the March 15 CFR that we predicted. Some possible explanations are because of the assumptions we placed in the training dataset for the prediction model, such as 30-day constant covariates that include policies. This assumption covers 64 of the covariates. Another assumption is linear growth in the distribution of vaccine. And now, Sam will present our summary and solution.
Thank you, Has. So what is the takeaway from our project? Our model has verified that a higher percentage of Black is associated with 33% higher for COVID-19 case fatality rate. To mitigate these issues based on our risk model, we suggest some surrounding factors should be focused for actions. For example, age over 65, more comorbidities, higher insurance rate, and lower COVID-19 vaccination rate. As you can see from IRR, those all contribute to CFR in different degrees. So in terms of the interventions, there are certainly many ways to address those. As a pharmacist, I see a lot of opportunities that pharmacy can help. So we believe by increasing access to pharmacy and the service it provides can help to mitigate this disparity efficiently. For example, CMS has mandated Medicare to provide comprehensive medication review for all Part D beneficiaries to promote their general health by addressing medications-related problems, which is actually lower utilized in Black populations. For uninsured patients, pharmacies are accessible and they help patients to address the drug costs or find alternatives when it's not affordable to them. And besides getting a COVID-19 vaccination at the pharmacy, it is also a great place to approach patients, take their questions, and to address vaccine hesitancy. Last but not least, our prediction model has produced a higher accurate result to identify high CFR areas. So different stakeholders like state health departments can identify which county needs more immediate support for early intervention and prepare for the future. This concludes our presentation. We thank you for all your time. We are now open for questions if there are any.
Thank you, Team 18.
This was really well done. I had a question. I wonder how much of the lower vaccination rate had to do with the fact that the prioritization was based on age and then essential health workers, and what the overlap between the population that's Black and those age profiles and job profiles, what interplay that may have had in lower vaccination rates. So just curious, based on what you've seen and based on the prediction, would you consider a slightly different policy or recommend a slightly different policy, if you would, in terms of who gets prioritized? Is it always age-based, or does comorbidities and race play a factor in prioritizing so that we might reduce some of that impact of disparities on healthcare?
Thank you so much for your question. I think in terms of the concern of if I'm interpreting your question correctly, if we can sort of like interpret the vaccination rate and sort of see like the disparity because they are essential workers, or like they are age over 65, or they have more chronic conditions, so they are more eligible, maybe in the percentage of, maybe in the majority of the white percent. So I think based on our model, we see a higher percent of the higher Black percent has higher age over 65. So if Sam can go back to when you have the slide of the covariates, you can see that we actually have higher 65 and above, and chronic conditions, they're actually higher in that prevalence as well. So in terms of like the second, I think phase 1C, I'm not sure about the phases, but But in terms of like the comorbidities were like over 65 and above, we do see like a lower trend in the Black community, even though they have higher percentage in all those categories.
I have a quick question. So your model clearly produced very similar to results to validated data. Very impressive. Cool to see that kind of overlay. I'm curious, what of this is COVID specific? Is there any reason to assume, did you compare the CFR for any other diagnosis or disease? We know that equity in healthcare in America is a serious issue. And so I'm just curious, like, what is the CFR for COPD comparing these two cohorts? Is it similar? I don't know, maybe you don't know. I just am curious, did you find, or what's COVID-y about this, if you will? I'm curious.
Yeah, I think I can take that question. So unfortunately, we don't look very detailed in those comorbidities, like separate those like high percent of specific comorbidities versus low percent of comorbidities. But that's definitely something we can look into, like see what's the interaction between comorbidities and the races, like in different like, Black.
I'll kind of clarify. So is the CFR for these two cohorts for heart failure 33% higher or the same? The reason why I ask is, like, there's structural issues probably that you've touched on. Many of your variables are structural issues in our healthcare system. And so I'm just curious, it'd be really cool to know if COVID exacerbated or possibly even tried to be a more, equality-based healthcare delivery because of its novelty. I don't know. I'm truly just curious. Maybe something cool to follow up on. Thank you.
Yeah, that's an interesting question, Nick. I was going to ask not as creative a question as that, but in the same vein, which is, there are other prediction models out there related to CFR and other kinds of COVID outcomes. Although, like I said, I like Nick's question about whether the model is essentially the same if the outcome is CFR for any other disease. How is this model or your approach to building this model different from other ones that have been developed in the literature, in the public domain?
So I can that questions. So compared to the first article, we compare on the right hand, the comorbidities, they have more accurate labels. The comorbidities we have, that is just for Medicare populations. So it might not reflect the overall comorbidities in that county. That's data we can have from the HHS data set. And I don't know if In or Has have any other insight for that.
Yeah, I can speak a little bit on the data perspective and also the outcome perspective. I think our strength, our uniqueness is probably comparing the two, like Sam has mentioned in the presentation, that we are trying to see what is the severity of the COVID-19 virus instead of how many cases that we got, how many deaths we have. And then there's like a lot of data. I would say that one of the limitations that I definitely see in our model is the policy data. And I think this is also one of our strengths for the policy data that we have. Certainly that can be improved, but I think one of the strengths would be including those policy data and the vaccination data, and also the county characteristics that I find it would be our strength in the prediction model.
Well,
thank you.
Thank you so much, Team 18. Now we move to our very last team, last finalist team, Team 16.
Thank you, Pinar. Just give me 1 second. Hello, everyone. We are Team 16. I am Samya, and I also have Neil, Christina, Martin, and Yash co-presenting with me today. So similar to the previous team, we are here to talk about how the pandemic has affected different racial and ethnic groups differently. However, instead of looking directly at the COVID-19 death rate, we are defining a new metric called the Covert Burden, which helps us in encapsulating both the physical well-being and health infrastructural support for the different racial communities. The primary objective is to establish how we can effectively model the burden that COVID places on different racial and ethnic communities. There have been several research studies into how outcomes among patients with COVID-19 differ by race and ethnicity. The results show that the likelihood of receiving a positive COVID test is higher among Black and Hispanic patients. After accounting for various comorbidities, it was found that infected Black and Hispanic patients were no more likely than white patients to be hospitalized. These groups are not innately more vulnerable to COVID-19, but are more often exposed because of social, economic, and environmental factors due to historic and systematic racism. The racial disparities in economic well-being, physical and mental health is something that is well known and researched in years preceding pandemic as well. But how these disparities look during the pandemic is something we will show via our basic exploratory analysis and spatial temporal modeling. The primary objective of this presentation is to establish how we can effectively model the burden that COVID places on different racial and ethnic communities, and to also understand how to effectively present a tool that does this at a county level when presented with weekly data and can do this while accounting for economic well-being as well. The model can both forecast the COVID burden and can draw inferences and provide metrics about how it happens for different racial groups over time in different counties. I'll hand it over to Neil to explain the exploratory data analysis that we did.
The economic well-being and physical health outcomes also have an effect on mental health. This effect has been amplified, especially during the pandemic. The plot that you see shows the percentage of the population suffering from anxiety or depressive disorders, sorted by different racial and ethnic groups, and how that rate changes over the weeks as we entered the pandemic. As compared to the 2019 data on the right, we have more average occurrences of anxiety and depression. So it seems that it went up as we entered the pandemic. And this was especially true for Black and Hispanic Americans disproportionately. We will now look at the same plot, but now with respect to the number of COVID cases as well. As the COVID cases increased over time, the disorder occurrence rate also seems to increase. And the national mental health cases correlate directly with the 7-day moving average COVID cases. I think we can all relate to that. As the cases went up, we were more and more anxious. This simple exploratory data analysis might not be enough to shed light on how COVID has placed the burden unequally on different communities. The National Center for Health Statistics partnered with the Census Bureau on an experimental data system called the Household Pulse Survey, from which this data was collected that you see. And this data was collected in 3 different phases, which were discontinuous, and that caused the gaps that you can see in the right plot for the mental health. And this affects the usability of the data. There might even be confounding factors that might not show up until and unless included specifically. So we have to attend to these data issues in a more intelligent way and when we are thinking about modeling. However, it is evident that COVID has affected several aspects of our lives. And it is also evident that there might be disparities in how different racial groups are affected differently. This merits a deeper investigation. We can also look at other potential covariates for a better and in-depth understanding. The economic well-being is something that has also been affected during the pandemic, which we will investigate in terms of unemployment rates and median weekly incomes for different racial groups. As per the Bureau of Labor Statistics data, unemployment rates are higher among the Black adults both in pre-pandemic times and during the pandemic. Here we can see that the unemployment rates in 2019 in purple and the 2020 rates in pink. While the unemployment rates have increased for all groups, it is higher for Black and Hispanic Americans. Now, I'll hand it over to Christina to talk about weekly income disparities among different racial and ethnic communities.
Thanks, Neil. So on this slide, we have the median weekly income in the fourth quarter of 2020 separated by race. The height of each number in this graph represents the percentage of each race that is fully employed, while the number itself is the median weekly income. So the heights of the numbers show the same trends in unemployment that Neil talked about on the previous slide, and the numbers indicate that there are racial disparities in median income. So having looked at economic disparities, now let's look at disparities in COVID health outcomes. Here, we have the percent of patients on mechanical ventilators and the percent of in-hospital deaths separated by race. We can see from this plot that the Black population has the highest percentage on mechanical ventilators, as well as the highest percentage of in-hospital deaths. So seeing these differences across races, we decided that we wanted to build a model that quantifies racial disparities in the effects of COVID. So to do this, we needed a metric that captures both physical well-being and health infrastructure. And the way we did that was to create the metric that we called COVID burden. So this is a county level metric that was based on a metric suggested by the CareSat FAQ for the hospitalizations at the facility level data. The metric from the CareSat FAQ is the facility metric that we have listed in the top left of the slide here, which is computed by dividing the number of COVID patients in a facility by the number of adult inpatient occupied beds in that facility. COVID burden is similar to this, but it is defined on the county level, and it is the proportion of COVID patients among currently hospitalized adult patients in a county. So to calculate it, we took the total number of COVID patients in the county and divided it by the total number of occupied adult inpatient beds in the county. So using the sum of COVID patients and the sum of the occupied adult inpatient beds allowed us to use more of the facilities in the data when we did this aggregation. The reason this is the case is because some facilities would report 0 adult inpatient beds occupied while reporting a positive number of COVID patients. And so if we use the facility metric, then this would result in us having to divide by 0. For COVID burden though, because we're taking a sum across all the facilities in the county, as long as one facility has a positive number for the number of adult inpatient beds occupied, we can still have a valid metric and include hospitals that reported 0 occupied adult inpatient beds. In addition, some facilities might only report the number of COVID patients or just the number of occupied inpatient beds. And so taking the sum also allows us to incorporate these hospitals which have missing values. So after defining COVID burden, we still had to address suppressed values in the data. And the way that we chose to do that was to replace those suppressed values with the minimum value of 1. We did consider in our analysis what would happen if we replaced it with, for example, the maximum value of 3, and we found that that did not change our conclusion significantly. So after creating the metric COVID burden, we chose a model that can answer the following questions. First, what is the COVID burden for a particular county? And how does COVID burden vary across racial groups? In addition to these 2 questions, our model can also quantify the effect of the median income on COVID burden, as well as how the COVID burden in nearby counties affects the COVID burden of a particular county. Our model also allows us to account for the effect of COVID burden from previous weeks within a particular county. Okay, so now I will hand it over to Martin to describe our model in detail.
Thanks, Christina. So after cleaning and aggregating the data in a manner my friends just described, we had 31 weeks of observations spread across 2,032 counties in the United States, and we sought a model that considered the three large components you see here on the slide. We knew we had a network structure inherent in the spatial layout of these counties, the flow of people and resources between them, and the coronavirus is spread throughout. We also had county demographics that Soumya and Neil mentioned, some of which we are interested in studying directly, like the racial components. Others we understood we needed to control for, like economic factors. And finally, as the coronavirus and COVID pandemic evolved over time, we needed to consider the temporal aspects of that. The mathematical object that put together all of these components for us was what's called a network auto-regressive model, which performs a regression on network neighbors, node-specific covariates, and nodes' previous values. The network aspect I will talk about first. So on this slide, we see the network on top of which we were able to model our response. Importantly, this is not the response itself you're looking at right now, but the network structure we developed to represent our data. The dots or nodes themselves represent the centers of counties for which we had enough data to draw meaningful inference. The lines connecting them define our network. Two county centers were connected if they were within 50 miles of each other. We chose that threshold to represent a reasonable flow of people between them, working, living, seeking treatment in neighboring counties, as well as shared resources. Also, though not pictured on this map, we did have observations in both Alaska and Hawaii, but they were not connected to each other due to distance and not worth displaying here. But just like the points you see in the west and southwest parts of the United States, they're still part of our network. They just don't have any neighbors in this network structure. The network information, the important information for you to carry forward from this slide is a sense of the network we just defined. A network autoregressive model estimates the possible influence connected counties exert on each other. Similar to an autoregressive term in time, this defines an autoregressive-like term in space. We believe this was an important element to better isolate possible demographic effects, which I'll discuss in the next slide. So like we said, we had covariates that we were directly interested in and some that we needed to control for. Gender and economic factors like median household income were included, as well as the racial breakdowns of each county. We used the 2019 Census Bureau and 2019 Department of Agriculture estimates for those covariates. Now, we think it's reasonable to assume that the gender and racial breakdown of counties did not change greatly over 2020, but the median income likely changed. However, we're including it in our model as such to reflect more affluent communities' ability to invest in a more robust public health infrastructure pre-pandemic, which is part of the response Christina defined. And on this chart, we see how indeed a higher median income was associated with a lower COVID burden. Here and throughout the next few slides, a negative coefficient estimate is positive or good thing in public health sense. You want a lower COVID burden. Next, the network term estimated the effect connected communities had on one another. It is positive, as we see here, which we interpret to mean neighboring counties perform similarly and that there is some dependency shared between them. A much stronger effect, unfortunately, is that the male population, if the male population is higher in your community, that is associated with a higher COVID burden. Strongest of all was the temporal autoregressive factor, which reflects the fact that your numbers last week strongly influence your numbers this week. These were the covariates and correlations we accounted for in order to better isolate any possible racial component, which I will discuss on the next slide. So this is what we are most interested in drawing inference on. We included the ratio of these demographics to the white population in each county. So what we have here is an estimated increase in the COVID burden associated with a 10% more community members of a specific racial group relative to what change you would see if the white population increased. One important conclusion we drew was that counties with a higher white population saw a decreased COVID burden. And now if there wasn't any racial component, all of these values would be zero because we've baselined relative to white change. But unfortunately, we see that there is an increase in the COVID burden associated with each race, with Black and Native American populations feeling that most acutely. I'll leave talk of what we can do about this problem that we've identified to Yash, but first I want to mention that all of the estimates I've discussed here were significant at the 1% level, providing strong evidence for the network and temporal aspects of our model and strong evidence for the gender, economic, and racial components I mentioned. So these are the conclusions we can draw from the estimated model directly. Now I'll turn it over to Yash, who will describe the value this model has in shaping public policy now and as more data becomes available. Thanks, Yash.
Thanks, Martin. So having seen how our model can describe disparities across different demographics, I'll talk about how our model can be used for real-time resource allocation. So the data we worked with in fitting our model runs up to February 26th, and this plot what we see are the predicted values for COVID burden by counties for the week following February 26th. So the resource allocation strategy can take these predicted values into account to ensure that sufficient resources are directed to the counties where it is required the most. One of the key resources that we want to focus on currently is efficient distribution of COVID-19 vaccines. And as we move to the next slide, we see the percentage of population that is vaccinated so far across different racial communities. I should mention that the vaccination data from CDC does not provide data for different races combined over Hispanic and non-Hispanic communities. So we only show non-Hispanic vaccination data here. We would ideally want that the communities bearing the most burden should also be the ones being prioritized for vaccination. And we do see that based on the most recent data, Native American community, which was predicted to have been the most affected by COVID-19, ranks high in terms of partially or fully vaccinated individuals. However, the Black community, which was also predicted to be one of the most affected from COVID-19, ranks last in this list. So we really need to prioritize vaccinating these communities. And finally, to wrap up, I'll talk about some key takeaways from our project. So in order to understand how COVID-19 affects different racial groups, we first studied the disparities in economic and mental well-being that already existed before COVID-19. And in order to understand the COVID burden, we created a variable that took into account physical well-being as well as the medical infrastructure. We found that the disparities exist across different racial communities and medical and Native American and Black communities are the most affected. So our policy recommendation is to take this burden into account while allocating resources. And as of now, our vaccine allocation policy is not well suited, particularly for the Black community. So as we emerge out of the current pandemic, we need to take a deeper look into how disparities exist in terms of access to medical infrastructure available to different racial communities, and prepare ourselves to avoid making similar mistakes when the next medical crisis arises. So that brings us to the end of our presentation. We would like to thank you for your time and attention, and we'll be happy to answer any questions.
Thank you, Team 16.
Team 16, Michael Jones here. Wonderful job, very comprehensive look at a lot of information. My question is related to trust in the healthcare community. Did you guys look at information related to the Black community's trust in the healthcare industry as a factor in why they may be least vaccinated?
Yeah, I can take that question. So yes, we did not explore that through our models, but while going through the literature, we did come across some surveys that talked about why the Black communities are least vaccinated. They pointed out that lack of information, lack of access to internet for making online appointments, and lack of reliable transport even could be contributing factors in explaining these disparities. In terms of our model, we did not directly work in as to how trust affects these vaccination rates. But yeah, that is a really good point, and it's definitely worth exploring in future.
Thank you.
I have a question. This is Pam. Again, all of these presentations have been really fantastic, so well done. I'm wondering if your model is sort of in terms of resources, sort of a one size fits all. So you talk about it in the context of vaccines. thinking about other resources like testing sites, would we use this same model, or are there changes that you would make to it depending on sort of either where we are in the pandemic or what kinds of resources we're talking about?
Yash, do you mind if I take this one? Thanks for that question, Pam. I think the vaccines come in the back end as part of our policy recommendation. And so one thing, by having this at county level, we can imagine taking its output and handing it to each state individually and just saying, you have this priority, like the map that Yash first showed us. Here are like the high priority locations. And then within each state, they can administer what they know probably better than we do, that specific location is lacking. So you're right that as this pandemic evolves and we anticipate any future crisis, we can use this to target at-risk locations, and then local leaders can allocate more appropriate resources. I'll also let my teammates add anything if they need to.
So it sounds like what you're saying is that I could use this to say not just which counties we should maybe have a more intense vaccine campaign, but also those would be the same counties where we would want to do more testing or more other types of outreach.
Yeah, absolutely. So the response that we modeled that Christina defined, we came across to try to model both the pandemic itself, the numerator of this ratio she defined as the occupied hospital beds divided by the available beds. So if you have an undue number of cases hospitalized, you're going to show up on this map, or if you have a very light infrastructure as measured by beds. And so this could be retooled to incorporate a different sort of denominator that you're capturing or that you want captured to measure infrastructure. But yeah, definitely.
Do we have other questions from our judges for team 16? Well, we are almost on time. We're 4 minutes, a little bit delayed, but so you have all seen in chat that Kim has put in a Hopin event. It's a networking event, which the best I can characterize it is like a speed dating, where you just get like 3 minutes to talk to each other. You randomly get matched to a person. So please join us in Hopin so we can all get to kind of chat around and relax. I mean, I just am so impressed with all these teams. It's just that it makes me so #UMN proud, and just the breadth of the analyses, the representation and the strengths of all these different disciplines we have. It's just really, really nice to see. So thank you to our competitors, our finalists, our audience, our judges, first round and second round, and our sponsors. I mean, it's just like really, really impressive. Thank you so much. So in a minute, we invite the judges to the deliberation. We have a separate link for that, I believe. But for everyone else, please join Hopin, and we've invited our judges to come in and join in like maybe 10 minutes or so. Thank you again, and please stay in touch with all the work we're doing at the University of Minnesota, and hope to see you all in future events. Thank you.
Great job.